Ryan Stanton here with the ACEP Frontline, joined today by Dr. Gillian Schmitz. She is, well, I can't really say because she's working on new gigs right now, but it's all kinds of, we'll talk to her about it. The most important thing is she works with us with ACEP on the board, elected to the board in 2016, got her medical degree from Loyola Stritch School of Medicine, Chicago, 2004. Then spent some time at the University of North Carolina learning the wares of emergency medicine. And as we were talking about just before we got started, she has some experience all over the country. Her husband is in the military, and thus her emergency medicine skills have been experienced through many parts of the country, currently now down in Texas. So Dr. Schmitz, thanks for joining us here on the Frontline.
Thank you so much for having me. It's a pleasure to be here, Ryan.
So let's talk about that a little bit. Give us a little background on where you are, where you work, and kind of your flow, and then how that plays into you being able to be an active leader of emergency medicine.
Absolutely. So I am currently an associate professor in the Department of Military and Emergency Medicine at the Uniformed Services University of the Health Sciences. And I work in the emergency department at Brooke Army Medical Center in San Antonio. And I have traveled quite a bit with my husband's career. We've practiced emergency medicine now on the East Coast, West Coast, Midwest, and now back in Texas. But I think that's given me a very broad perspective of how different our practice environments can be. And my background is primarily in academic medicine, but I've also worked in the community and rural emergency departments and even freestanding emergency departments and now military emergency departments. And so it's given me a pretty good context of different systems and different ways to deliver care. And I've been involved with EMRA and with ACEP really since I was a second-year resident at the University of North Carolina. And it inspired me to get involved and to make a difference, and found that my involvement with organized medicine is really what charged my energy and kind of gave me passion to doing what we do every day at the bedside. And a couple of years ago decided I was ready to take that next step and to run for the board of directors for ACEP. And it was intimidating at first. There weren't at the time that many women in leadership in emergency medicine. I was considered a young physician. I am now technically an old physician because I am now more than 10 years out. And I didn't know if I would be able to balance it with everything else going on. I have two young children. I have two girls who are now age 7 and 9. But I have found it to be one of the most rewarding things I've done in my career, and really helps offset my professional satisfaction and enjoyment with what I do clinically and academically in my other kind of part-time jobs.
ACEP's turning 50 this year, and during that time there's been a significant shift in the demographics of not only medicine but emergency medicine as well. And so when you had early meetings of ACEP 50 years ago, it would have been a room full of middle-aged and gray-haired white men, and now we're pushing more and more to really more than anything reflect the characteristics of our patients, a diverse population made up of everything America has to offer. So, give us a perspective as a young female physician leader of that evolution of. First, of women in medicine. Now, almost all medical schools are at least 50-50, if not actually leaning more female than male. My first class, and I graduated 1 year before you did in 2003. That's when I graduated, and ours was the first class that was 50-50. And it's been a huge evolution. And with that 50-50, the leadership has now really starting to push as these women physicians are really starting to mature, and evidence is showing the care they provide is equal, if not better, in many cases, and actually almost all cases, than what our male counterparts are providing. How do you see this progression, this evolution? I mean, you're right here on the front of a wave of the shift in not only medicine, but the way leadership happens and the way the healthcare is going to be provided.
It does. I think this is a really exciting new era and time for us to be involved in medicine. And I still think we have a long ways to go in different aspects of leadership and diversity, but I think we're making changes. And I think there's been a very intentional look at that. And a lot of thanks goes to past President Becky Parker for really driving it home and making it her initiative while she was ACEP president to drill down and look at how we mentor young physicians, of how we recognize diversity and inclusion, really at all levels of leadership within the college, and speaking with other organizations to really focus on this, not just within ACEP, but nationally within medicine, of realizing that there are some gaps there and they're sizable, and we need to start honing in on why those differences exist and how we kind of level the playing field. So as a young female, I will say this is a very exciting time to get involved and to get recognition for things and to be able to break that glass ceiling.
What are some of the challenges? So my wife's a physician as well, and she still faces a fair amount of challenges. And really interestingly, it's not from as much the healthcare side of things, but very much the, I guess, either the anchoring bias or the stereotypes from our patients that women are nurses and men are physicians, and it goes both ways. And so my wife still comes back and talks to me and, wearing her white coat and doing everything, says Dr. Stanton across the front. And she says, yep, this so-and-so called me. I got, they wanted to talk to me because they said, I've never seen a doctor and all this other stuff. And what are some of the challenges that you face on a daily basis, other women in medicine face, that can still be pretty frustrating that men really just don't understand just because we take for granted the situation that we're in?
That's a great question. I think there's many, many examples of how that plays out. I think almost every female in medicine has experienced that, where you're wearing your white coat, you have your name bag on, and someone routinely calls you a nurse, and after you correct them, they say, "It's a very nice nurse. When am I going to see my doctor?" And you're like, "No, I am the physician." That happens quite frequently. Even at I would say, hospital level, in C-suite and other meetings that I've been in, there are, I think, unintentional, but definitely biases there. And there have been multiple instances where the men in the room within a boardroom will be called doctor, or their title, and then they'll call the women by their first names. That happens routinely. And sometimes when you try to point that out, some people will take it as constructive feedback. Other people kind of blow it off and get irritated that it was even brought up. Other times in meetings, there have been notices that sometimes men will take credit for other women's ideas or kind of tail dive off something that was said. And this was actually in the Obama administration. The women had kind of brought up this process of amplification, of really recognizing when another woman had made a point or said something to kind of highlight their kind of acknowledgement of what they said. And we've been doing this at a hospital level, within the board level, multiple ways to amplify other people's ideas and to really recognize women who are contributing. I think in general, many women tend to be less confident about really putting their name out there, and that art of self-promotion, I think, is challenging for many women. And oftentimes, this plays out in a number of ways, whether it's promotion, whether it's tenure, whether it's salary. There have been some numbers out there that even within emergency medicine, female medical directors on average made, I think, $288,000 a year, and male medical ED directors made $325,000. So there's salary gaps there that are objectable numbers. There's other kind of subjective experiences that people have had, but I think this is a very common experience, and I think because of that, it's brought together a community that's made up really of both women and men. But Fem&EM is one example of they've had their first conference last year of really empowering other women and how to avoid some of those obstacles and how to really get through some of those challenges and how we can work together as a specialty and as an organization to help promote women in emergency medicine. And I think we are making some significant headway there. I think with terms of other representation, for instance, African American in medicine, we're way behind the eight ball, not only in our specialty, but even at a medical school level, that such small percentages of students are actually making it into medical school, that getting them into residencies and into leadership positions has been a challenge, and something that I still think we have some ways to go on.
Exactly. There is a huge interest and need to get significant diversity throughout the healthcare community. You mentioned some of those things, from everything from, and these are unconscious little things that people do, is they'll call the male physician doctor and they'll call the female physician by their first name, and not giving credit or taking credit. And the other one that has been really big is that males will interrupt the females. There's been studies on how much quicker a male will try to correct or interrupt a female that is speaking or having an idea. And it amazes me, and it's amazing how ingrained a lot of that stuff is. And I think there's a huge contribution too now that everybody in the hospital is wearing a white coat. So it is, it's not unusual to see people of other educational backgrounds in white coats. And honestly, the bastardization of the doctor name, now we're almost having to go in and say, I'm your medical doctor or I'm your physician, because, actually, honestly, there was an ad that came up here locally, this giant Dr. So-and-so, and at the bottom of chiropractic medicine or whatever, but it was hanging his shingle out as a full-blown doctor, as a chiropractor. And sure, he's got a physician, it's not a physician degree, but he's got a PhD, but at the same time, it's very misleading, and I think there's a lot of things we are doing that are making it more difficult to give female physicians the equal recognition and everything that male physicians have, just because we have this huge shift. And if it were very simple, this transition, a clear distinction, but now we're just kind of muddying the water all around of what is the physician and who is the physician, that I think it makes it challenging. What are some of the things we can do as medicine, as emergency physicians?
Absolutely. Yeah. I think if you look at a leadership level, you really have to go to look at kind of a grassroots efforts of where things are starting. Who are your members? Because you have to have people who are qualified and have had the appropriate training and mentorship. And I think that's been a huge part of the barrier. So within ACEP, we're not looking just at the board level, but within the chapter leadership, within the section leadership, when we have conferences and panels, really taking an intentional look at who is representing us and how do we help bridge that. AWEP, which is the American Academy of Women and Emergency Physicians, has what's called the LEAP program, which is really meant to help foster that development and that mentorship early on to give people those skills. And, I'm a big advocate for, some of my biggest supporters have actually been men, and two of which were influential on my decision to run for the ACEP board. And I think when I had questions about whether I was ready for this, and many women and men can suffer from imposter syndrome, but it's more common in women, and that is that even though you are qualified, you have the essential skill sets, there's this kind of pervasive feeling that you're not ready, that you don't belong, and that people are going to quote unquote figure you out. And I definitely had that, initially of going into this of, do I have to go up and give this big speech in front of people and go to all these different receptions and meet people? And do I know enough, had enough training and background to make me prepared for this? And it was really several of my male mentors who sat down with me and said, Gillian, you are so ready for this, and you're going to give us your best shot. And if you've already questioned yourself, you're giving up. And this is exactly why you have to run and make sure other people understand that there are opportunities for people just like you who want to get involved in leadership. And I thank them for giving me that strength and for giving me that confidence to help get me to that next step. And I think that is the biggest thing that I see in many different, particularly young physicians, is just that lack of self-promotion and how to negotiate and how to really market your skills and put it forward in a way that will help advance your career. And I found different resources through the young physician section, through ACEP within my hospital, and some of the faculty development courses really helped give me those skills that in particular ACEP, has been such a huge part of my career, whether it was how to run a meeting or how to chair a committee, that those faculty development skills really came without my even knowing that they were going on. But the connections, the networking has been a huge part, I think, of any career. And if anything, the different committees and the different meetings helps introduce you to other leaders in our field. And our emergency medicine is such a small world when it comes down to it, that when it comes time for instance, for me looking for a job in San Diego, because that's where my husband was stationed for a year, and knowing that market is so saturated. But within a few phone calls to folks I knew in California and within ACEP, I had a number of opportunities that became available. And those, again, that networking became so important, and not just finding a job, but of continuing advancement in my career and getting promoted and letters of recommendation that I have found incredibly helpful. So I think mentorship is one thing. I think that networking and learning how to self-promote is a big part of it. But third is really reaching out of what are those gaps and how do we get people in that door? Because I think once you get them there, they can get hooked very quickly, and there's so much to offer physicians who are interested in getting involved in leadership, whether it's, again, young physician medicine, whether it's EMS, whether it's ultrasound. There's so many niches within our specialties and so many opportunities to get involved. And I found like ACEP has provided me with so much of that I'm anxious to give back and share those opportunities with others. And that's now a huge part of my job within the military is mentoring our men and young women in uniform and helping provide them opportunities to advance their skills in their career and give back.
One of the cool things you guys are doing that leading the way, and I don't know that you even realize, is you between folks like yourself and Doctors Haddock and Liferidge, is that you're breaking this traditional hierarchy of medicine as well. Whereas at one point, you were 20 years in, you'd get your gray hair, you would run for the board. We'd run for office and leadership then, and then it was it's this person's turn or this person's turn in this role or whatever. And I always found that to be a little bit off-putting. And what you've done is to engage younger physicians that are still in the front half of their career, that still have passion and energy and new ideas that bring it. I think it brings more of a balance. So not just adding the female perspective to the leadership roles, but also breaking a lot of the traditions that have happened through medical societies throughout decades, of making sure that everybody, from coming out of residency to early careers to mid-careers to late careers, are represented as well. How do you see the face of leadership, especially in emergency medicine, changing as we move forward, as we're encouraging these dynamic young leaders to pursue positions and run for office?
Absolutely. I think diversity means so many things, and I think that the age diversity is a huge part because that's who our members are. And we're seeing a growing number of our members are young residents and young faculty and people right out of residency who have very different needs and concerns than someone who's been out in practice for 20 years. And I think having representation in our leadership of different sort of generational gaps gives a better understanding to that. A few examples, that come to mind are social media, right? So a number of years ago, we used to communicate primarily just through newsletters and websites, and many of us have been very active in trying to bring things into the 20th century. And as you're doing these amazing podcasts, we know learners prefer that now, right? People don't read textbooks as often as they used to, and many times they want to supplement their learning with audio recordings, with video podcasts, of making things kind of shorter and high yield, of communicating in real time. And so having a newsletter article come out a month later is much less effective than a social media response that we can generate and kind of get a pulse on our membership of what the hot topics are, what our members' concerns are, and seeing really a change also in the demographic of our members. And I think, historically, we used to see a lot of single parent homes of, one full-time working person and a stay-at-home parent. And now a lot of that's changing where we're seeing, like you said, dual physician families, of single parents, of non-traditional families, and keeping up with that. And one of the things that, we started looking at really was even childcare at conferences, and realizing that, like myself or Becky or others on the board who had kids, if that's been a barrier to leadership of what do you do when you have young children and you can't bring them to your meeting, but you'd like to be able to spend time with your family, of exploring different options that we can help support young leaders of getting involved and breaking down those barriers and identifying what their needs are to help progress their career and make it more friendly. And I think having that representation of different backgrounds really helps. And if you look at our current board, it's really well diversified. This is probably the most diverse our ACEP board has ever been. And we have, I think, 5 people who are in their 60s. We have 1 in their 30s. We have several of us that are 40s that really represent a very diverse background, as well as our training. Close to half, but less than half are academic. We have a couple of us who are military. We're split almost half and half between large group and small group background. And then really the skill sets that come into play are really important. So 7 of us are involved actively in hospital leadership and have experience in the C-suite. 3 are active researchers and publish peer-reviewed publications. 11 are involved in teaching, 4 are involved in EMS, 5 have been involved in quality and safety and ethics. And really all those different backgrounds are helpful whenever we have an objective to look at things through different lenses. And I can't tell you the number of times that I've gotten material that I really thought I had a strong opinion on something. And then after hearing different board perspectives really changed my mind on how I would approach it. And I think that diversity is so important in any organization, because if you all think the same way, you're missing half of your membership who may think very differently. So as contentious as sometimes those meetings can be, I think it's really important that we have those discussions and that we see things through different perspectives and lenses to help give us a balanced view that represent really our members and how they might feel on a particular topic.
Let's talk about a little bit about young leaders. You and several others have really blazed that trail. What are some words you have for the young physicians, male, female, all races, everybody, let's just across the board, that are finishing their residency? They're getting active right now. That's one of the challenges for ACEP, is that time from residency transitioning to attending. That's, if you're going to lose members, that tends to be when it is. What are some words for folks, not only to get them involved and the importance of involvement, but also developing in roles in leadership, not necessarily the board or president, just the full breadth of involvement within leadership within the college, whether it's committees or sections or whatever it may be?
So in addition to just getting involved, I think it is getting involved in a specific leadership position. And I think there are a number of opportunities for young physicians to do this within ACEP that I've been able to take advantage of. I remember my very first meeting in the Academic Affairs Committee, and I sat down in this very prestigious room of very experienced and seasoned program directors and chairs and medical directors. And at one point, the whole room turning around and asking me for my opinion. And my first instinct was to turn around and see who was sitting behind me to think, who is this person? And I realized they actually wanted to hear what I thought. And I thought that was so great that a group could be so open-minded and include me, even though I had zero really real-life experience at that point in my career, to be able to contribute. And I think many people who are later in their careers are, one, looking for an opportunity to mentor others, but two, are also very busy, and they want younger people to help run with things and to help lead things. And I remember, as an example, out of residency, I had been named in a claim, and I was terrified of lawsuits, and nobody in my residency had trained me about what to do after you had been named and how to prepare for a deposition. And I had heard of this guy, Greg Henry, and had seen him on the medical legal committee. But I called him and was very intimidated, but thought, gosh, if I don't know this, I bet a lot of other young physicians don't know this either. And I would really be inspired and feel very passionate about putting together, some sort of resources or a podcast. And within a week, I got a phone call from ACEP and said, yep, we're going to fly you out to Dallas and let's film a webinar. Let's go through a mock scenario. Let's teach doctors and particularly young physicians about the stress from a lawsuit and how you deal with it and how you prepare for a deposition. And within a couple months, now I had a new mentor, and there were all these opportunities that then opened up new doors for me where I was lecturing on med legal topics. I was writing various newsletters. I was helping get some peer-reviewed research on and really doing what I wanted to do, which was at the end of the day teaching residents and young physicians how to avoid some of the pitfalls that I made and to help get through that scary period of litigation stress that I was wholly unprepared for, and to know that there was a light at the end of the tunnel and that I wasn't alone. And ACEP really gave me those resources. But I think it's very easy to show up at a meeting and to kind of hide in the back and just sit and watch. And I would encourage young physicians to take it one step further. I think the first step is being there, and that's half of the job of getting elected to anything is showing up. But then when you show up, of taking that next step of volunteering to help lead an objective or helping to lead a effort. And you'll be surprised, I think, at the outpouring of resources and support that we'll have for young physicians to take that step, as well as sort of naturally developing mentors and people who will help facilitate getting that objective done, that will help bolster your career and your confidence to stay involved and give you that passion to do what it is you want to do.
Dr. Gillian Schmitz, and that sounds like our next opportunity to talk and topic, the firsthand account of a lawsuit from a resident and young physician. That sounds like an incredible topic to discuss, and hopefully something we can have you back here very soon. How can folks get in touch with you if they have any more questions? You're a great resource for leadership and honestly really cool emergency medicine experience thus far. And I'm sure folks will be interested in that. How can folks get in touch with you? And I really don't need to ask because I know you've got Twitter as well as a young active physician. We're trying to still work on some of the older folks, but the younger folks I think this has been I remember coming back from SMAC the first time, and there everybody's got one, if not 20 Twitter accounts, and coming to, I think it was ACEP 15, and asking about Twitter, and I always got these cross-eyed looks of, the intrigued puppy dog look, and now almost everybody's got one, but I know you're active as well. How can folks get in touch with you?
Absolutely. So my Twitter handle is Gillian MD and the number 1. And then my email is gschmitz@acep.org. And I'm very responsive to both of those. But yeah, we're making a number of technical advances. We're even exploring for our board meetings, going to some virtual meetings and doing the go-to meetings and various methods of communication that don't fall just to the traditional face-to-face meetings to help make things easier and streamline our workflow. So I'm excited to bring ACEP into the 21st century, and we're getting there.
Your key role on that is going to be, when you do go-to meeting, is making sure everybody knows how to use the mute button. So that you don't have the background noises. And as I recall from a meeting about 6 months ago, somebody who decides to get very upset at something and lets go a long list of words that would get you banned from your favorite church, and unfortunately did not know that the mute button was not being employed at that time. So everybody acted. That's
unfortunate.
Everybody acted like they were insanely appalled, even though I know a lot of them use many of the same words. But very great talking with you. Enjoyed talking with you. Thanks for your time. I know we've gotten you, pulled you right out after the DMV version of credentialing and permissions for your work. So I appreciate the time.
Thank you so much, Ryan. It's great to talk to you, and have a great afternoon.
As for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, @everydaymed on Twitter, and we're also available on Facebook at our ACEP Frontline page. And I hope you'll keep tuning in and subscribing to the podcast. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.